Good morning, everybody, and welcome back to Journal Club. Unfortunately, we meet today and this week in some rather difficult circumstances with events that's going on in Ukraine. And first of all, we'd like to say from all of us, all our thoughts and prayers and wishes are with everybody who's been affected by this conflict. And before we get started, I'd like to invite, I think, Federica, who's connected, who'd like to give a brief announcement about something that's very, very important. So Federica, please, can I ask you to...
Good morning, Arif, and thank you very much. I'll just steal a few minutes just to say. Okay, can you see my screen?
Yes, please.
Okay, we know that this is a difficult situation and everybody is very sad and difficult to go on in our everyday practice. So GC Young Committee, and I really thank Pierluigi De Mola and Giulia Masero for their support, has proposed to GC Society to go on with fundraising. And so, as you can see in this link, we are supporting Italian Red Cross, which is giving a very high contribution for Ukrainian people and in this very crazy conflict which is going on. So everybody, we are young, we have to make something which is apart from interventional cardiology. So we really hope everybody can give a little contribution. This is the link. You can share, please share to everybody this link with this Facebook fundraising, which is going on for 1 month. And we really hope you can give a contribution, and this is really important for us. So thank you very much, Arif, for this little space. And I thank everybody in anticipation because I know that everybody is going to give a contribution. Thank you.
Great. Thank you, Federica. I think a very important message, and this is a fantastic initiative by GZ Young, and I'd encourage everybody to support it. Unfortunately, I think maybe the link or the screen didn't share. So for what we'll do is at the end of the Journal Club presentation, we'll leave it on for all participants to have a look at. And I'll leave it on for, let's say,
yes, of course, you can go to GZ page on Facebook, our official profile, and from there you can share, you can contribute, and you can share to everybody.
Perfect. That's great. Okay, wonderful. So thank you. Andrea, are you connected?
Yeah, sure.
Okay, perfect. So can I ask you to share your screen, please?
Sure.
So it's a great pleasure for me to welcome Andrea Marrone from University of Ferrara in Italy. And as expert, we're joined by Matteo Tebaldi, I know, who not only is an expert, but a real enthusiast and passionate about physiology, having worked with him before. So really delighted to welcome both of you back and looking forward to the discussions.
Okay. Hello, everybody, and good morning to everybody. It's a real pleasure for me to be here today at Journal Club. And today we're going to talk about the one-year outcome of the FIND PCI trial. But before diving into the detail of this paper, I would like to, briefly recap with some background. And several trials and studies showed that the rate of recurrent angina at 1 year after PCI remains between 20 and 30%, remaining on similar values regardless the kind of stent used. And as we can see here in the ARS trial, in which angina was present in 21% of the patient 1 year after PCI with bare metal stent, with similar finding observed in the DES era. And also nearly 30% of multivessel, so left main disease patients enrolled in the Syntex trial had angina at 1 year follow-up. This figure shows data from the Perspective Multicenters Registry, showing the distribution and percentage of FFR before and after PCI. As we expected, pre-PCI FFR was almost lower than 0.8, while post-PCI FFR was expected to be more than 0.8, but a total of at least 18% of the patients demonstrated post-PCI FFR of less than 0.8. Here we have Kaplan-Meier curves from the same registry of TVF 2-year follow-up show that patients with low post-PCI FFR showed a higher risk of target vessels failure compared to those with high post-PCI FFR. Similarly, patients with lower percentage of FFR increase, so less than 15%, showed an higher risk of TVF compared to those with higher percentage of FFR increase. So the defined PCI trial rationale was a study to assess the significance of functional evaluation with IFR, not before PCI, which has been shown to be a good guide to who would benefit from PCI, but after PCI. So it was a study looking at the question in what percentage of cases do we leave significant ischemia behind, defined by an IFR of 0.89 or less, despite good angiographic results. And what's the impact and the prognostic significance of residual ischemia in those patients? This was a multi-center prospective study with 100 patients in 562 vessels from 28 sites all around US and Europe. Whose aim was to evaluate the rate of abnormal, blinded, post-stented IFR and the pattern of residual ischemia as focal or diffuse. So here we can have the inclusion and the exclusion criteria. We can see here that both patients with ACS and CCS have been enrolled. Patients with at least 40% angiographic disease have been taken. And as for coronary anatomy suitability, both single vessel CAD, multi-lesion CAD defined as at least 2 different stenosis on the same coronary artery, or also multi-vessel CAD. As for the exclusion criteria, we can see instead that one of the main limitations of the study is displayed right here, so that very high-risk population of patients have been excluded by the trial itself. As for the study flow, we can see that IFR was performed in distal vessel whenever an angiographic lesion of at least 40% stenosis was assessed, just to make sure that there was ischemia in the vessel. After that, in case of positive results, so in case of an IFR value of 0.89 or less, the investigators were told to basically treat the vessels according to the standard of care and local customs. When the operator achieved successful angiographic results, they performed a blinded IFR and IFR pullback, which allowed to map out the entire vessels looking for pressure step up and gradients, even if the angiographically good results. Finally, a 30-day, 6 months, and 1-year follow-up was performed. As for the primary endpoint was the rate of residual ischemia, defined as an IFR value of 0.89 or less, while among secondary endpoint, one of the most relevant was the differentiation of residual ischemia among stent-related, focal stenosis, or diffuse disease. Here we have the principal finding of the trial. So one of the main findings was that 24% of the patients, so almost 1 out of 4 patients, presented with significant ischemia despite the operator thinking they did a good job on the angiogram. But important message is this: from the pullback, they found that the vast majority of these patients, and especially 82%, had missed focal lesion. So it means that if the operator had known about the stenosis, this could have been treated and potentially improved. Finally, the relationship between post-PCI IFR and clinical outcome is not yet established, and whether post-PCI IFR-based optimization is safe or not is still unknown. So here we have the objective of the 1-year follow-up of the defined PCI trial, and it was to assess the impact of residual ischemia on clinical events defined as both periprocedural and spontaneous MI, cardiovascular death, and target vessel revascularization. Then to assess the improvement in angina frequency defined thanks to the Seattle Angina Questionnaire score at 1-year follow-up. And then to perform a post-hoc analysis to determine whether there was a target post-PCI IFR value which was associated with improved outcomes. Okay, here we have the flowchart, and we can see that the post-PCI IFR pullback amenable for core lab analysis was available in 467 patients with 520 vessels. And here we have the baseline demographic features of the study population. As we can see here, the vast majority of this population consisted of men, mostly with hypertension and hyperlipidemia. quite half of the population had previous cardiovascular history, and the two main most represented clinical syndromes were stable and unstable angina. A post-PCI IFR value of less than 0.95 was the best discriminator for the presence of future cardiovascular events and angina after stent implantation. These findings, identifying a post-PCI IFR target of 0.96 or more as the goal for an optimal PCI results, is likely to provide a target for future improvements after PCI. And as for the results of the study, here we have data about the baseline. Here we have data about the angina frequency at 1 year follow-up. As we can see here, in IFR group, in IFR that more than 0.95 group, we have an improvement, showed a higher trend in Seattle angina frequency improvements, and at the same time, those patients with higher angina at baseline, so those patients with an angina questionnaire score of ranging from 0 to 60 at baseline, was those patients who presented an absolute change of 10 points of more at 1 year follow-up. In case of an IFR, in case of a post-PCI IFR value of at least 0.96. Here we have the distribution of the difference in angina at 1 and 12 months post-PCI compared with baseline in the Bayesian analysis in all the patients. We have here on the right side of the x-axis the magnitude of benefit for patients with post-PCI IFR or 0.95 or 0.95 or more. At 1 year follow-up, angina tended to be less in those patients with baseline daily or weekly angina. While, of course, patients with monthly angina at baseline or patients with no angina at baseline, angina frequency at 12 months follow-up was not related to post-PCI IFR. Here we have the results about clinical events at 1 year follow-up. Post-PCI IFR of 0.96 or more was associated with a significant reduction in MACE compared with post-PCI IFR of 0.96 or less, driven especially by a reduction of myocardial infarction and cardiac death. There were other fewer clinical events with post-PCI IFR of 0.96 or more versus those patients with IFR with 0.96 or less, including all-cause death, all myocardial infarction, and revascularization. Here we have Kaplan-Meier curves for cardiac death, spontaneous MI, or clinically driven TBR at 1 year follow-up. And we can see here that in this population with non-ischemic IFR value, so IFR value of 0.96 or more, the rate of adverse events was much lower than those in the population with ischemic post-PCI IFR value, and especially 1.8% compared to 5.7%. And these results are confirmed by Kaplan-Meier curves from cardiac death or spontaneous MI, show that 3.2% of patients with ischemic post-PCI IFR values compared with 0.0% in non-ischemic post-PCI IFR values. So for the limitation of the study, we can see that, as I told before, the FIND PCI trial excluded high-risk patients and all these patients with complex lesion in which the rate of residual ischemia may be more than 24%, and in whom the suboptimal results, so IFR of less than 0.95, may be as frequent as 61%. And then, of course, that the target of post-PCI IFR of 0.95 was identified thanks to post-hoc analysis, and so it requires prospective validations. As for conclusions, in 1 year outcome of the defined PCI, despite unsuccessful PCI, all those patients who were highly symptomatic at baseline without residual ischemia by post-PCI IFR of 0.95 or more tended to have greater improvement in anginal symptoms at 1 year follow-up compared with those patients with residual ischemia. And then that post-PCI IFR of 0.96 was associated with fewer rate of cardiac death, spontaneous MI, or clinically driven TVR, compared with those with post-PCI IFR of 0.96 or less. And then, of course, that the clinical effectiveness of IFR guidance to identify and eliminate post-PCI ischemia will be studied in the ongoing DEFINE GPS trial. Many thanks.
Okay, great, Andrea. Thank you. Nice presentation and a nice summary of this paper. Matteo, can I invite you now, please? So if you can give us your thoughts on this paper in this field, and then we have plenty of time. So if anybody does have questions, we'll be happy to take them, and you can come on and ask Matteo live. So Matteo.
Yeah, thank you. Good morning to everybody. It's my pleasure to be here today, especially because I think that this is a very, very important study. Because from my point of view, the study elegantly presented by Andrea is yet another shining sign inviting the new interventional cardiology to take the road of the full physiology approach. I mean that currently we have a lot of available data. They show how the angiographic evaluation is inferior to the functional evaluation at any stage of the PCI procedure. So in my opinion, the functional assessment should be the guide before, during, and after the stent implantation in a modern cath lab. But unfortunately, as we have shown in the ERI study, this is a very interesting paper, but we know that only the 10% of the operator use the functional evaluation to evaluate the final result of their procedure. So one of the most frequent reasons for this sub-use of the functional evaluation is the side effect of adenosine, and also the use of the pullback. Because we know that after the stent implantation, to perform a pullback is mandatory, but it is not easy to interpret and understand what's happening in our vessel during the procedure. Because we know that we have a lot of reason to have a suboptimal result with the PCI, like some effect related to the stent, so subexpansion or dissection, the presence of very long disease, the tandem lesion, the presence of spasm. So I think that to be able to have and interpret it in the good way, the pullback may be very, very important. So we know that to overcome this limitation, new tools have been introduced, like the non-hyperemic indices like the IFR, and also the angiographic-based functional assessment like the QFR. And I think that these tools have the advantage of not requiring the use of adenosine and allowing for a punctual pullback of the vessel. So probably once the cutoff to be obtained post-PCI has been established, like in this trial, now the real point will be to be able to plan a procedure that can first predict the result of the PCI. So something like the virtual PCI, and also guide the optimization of the procedure. So probably tool as the IFR and the QFR are the most suitable for this type of approach. And as Andrea has previously told us, the DEFINE GPS will investigate the IFR in this regard, while Simone and Biscali, on behalf of our group, have just submitted for publication the AQUA trial. And that is a trial that testing whatever a QFR-based virtual PCI plan is superior to a conventional angio-based PCI in obtaining an optimum post-PCI physiological result. So I therefore believe that this analysis of the defined PCI, but also previous studies like the OCAI, are very important because they introduce us to a new way of programming, evaluating, and assess the result of our PCI. So I think that these are very, very interesting study with some good point to analyze in the future.
Great, thank you. Thank you for that nice overview. We can perhaps take some questions now. Pierre, do you want to come on and ask a question?
Yes, thank you. Great presentation. And I want to ask maybe another reason why it is not so spread, the physiology is not so spread in cath labs, maybe is the maybe the procedural time comes to be longer just to search about a number that is maybe the post-PCI assessment is between 0.19 and 0.95, and you try to be as precise as you can, and then you can have a longer procedure that is associated with many bad things. What do you think?
Yes, this is a very good question, and but in my opinion, we have to forget this interpretation of the time of the procedure. So you decide that the procedure is fine when and is finished when you obtain a good result, and the good result is a good result for the patient. And at the moment, as the data presented by Andrea show us, if you obtain a good 0. Value greater 0.95 after the stent implantation, your patient have a very, very, very low event in the future. So I think that if we go to analyze all the study that advantage for example, the cabbage versus the PCI, we introduce this kind of approach, I think that we can, in my opinion, and I'm passionate as Arif said previously, and I think that we can change the history of the PCI. So I think that we have to change our mind, and define put the patient at the center of our decision in the cath lab.
And remaining in this field of physiology, in your opinion, just your opinion about FAME3 trial. What's your opinion about this?
So good. I think that it is not a trial against the FFR, but is one again a trial of stent versus the cabbage. So if you choose to do one PCI based on the FFI, you can use this kind of approach if you defer the PCI. So this is a trial on the functional evaluation. If you decide to have a approach like and choose about between the stent and the cabbage, this is not a study on the functional evaluation, but it's a study of the approach that you have for this patient. So I think is not a trial negative for the FFR.
So gray zone is bad. We have to looking for perfection in this case.
Yeah, I think yes. But it's not mandatory that you finish the procedure with the functional evaluation. You use the functional evaluation, but if you see that there is something wrong, you can use the IVUS to understand how optimize the stent or something like that. But at the end of the procedure, if you start the procedure with a functional evaluation, I think that actually in modern cath lab, this is important, is mandatory to finish the procedure with the functional evaluation.
So associate the imaging in a procedure that is
yeah,
it comes everything to be more expensive, but it's worth it.
Yeah, for sure.
Thank you.
Okay, thank you. So let's just take that discussion and continue with it with one of the questions in the chat from Guido. So Pierre, you mentioned in the discussions about, searching for perfection. So you've reached, let's say, 0.91, you want to try to get to 0.95, 96. And Guido's question specifically is, do you run the risk of over-treatment, or perhaps, increasing the stent length, increasing the number of stents? And do we then start to get this trade-off whereby we're trying to achieve perfection with the physiology number, but we're increasing stent number and stent length, which may have long-term consequences? on, let's say, restenosis, for example. So what's your opinion about this balance in this question?
Yes, it's a great question. And I think, in my opinion, that if we need to put another stent and we have a suboptimal result with the functional evaluation and then the procedure, maybe that we wrong something. Maybe that at the beginning of the procedure, we need a long stent. In this way, I think that all what I say previously, we need to plan the procedure at the beginning of the procedure. So I think that if you use the virtual PCI, and we are able with the pullback or with the pullback with the QFR, so the reconstruction of the vessel, to understand which are the point that need a stent and how long we need to put the stent. This may change the need of something something else to the procedure. So I think that to perform a planning of the procedure with the functional guided may be the answer to the question.
Okay. Then there's a question here from Giorgio about this relationship between residual, let's say, physiological ischemia and the high rate of clinical events. Could this just be that the type of disease that we have, if you have diffuse disease, you're just more likely to be left with this situation? And that's why these, it's a, let's say, a marker of global atherosclerotic burden, for example, that these patients are not doing as well?
Yeah, I think that at the group of Professor De Bruyne will going to answer this question, because if with all the study that they are doing, we understand that if we have a very long diffuse disease and the right choice is not to put a stent, we have the answer. So we need to, it's very important to have the answer to the question, to understand if what we are going to do every day in our cath lab is the right choice. So now we have the tool to answer the question, so we have only to wait for the answer.
Thank you. And a question from Rosella about when you have CTO and use of physiology in the setting of CTO for donor vessels. So for example, we have let's say, a occluded right coronary artery and a lesion in the mid-LAD, which is supplying collaterals to the right. How can we interpret?
Yes, the answer is what you are going to do. So if you decide to treat the patient, and if you want to, if you put the wire to perform the functional evaluation in the lady in this case, and the result is that you have a very low value of the LAD in the functional evaluation. If you don't open, if you are not going to open the right coronary artery, this vessel is under ischemia, because it's work also for the right coronary artery. So in my opinion, you need to treat the LAD. It's different if you decide to open to perform the CTO. So it's important to perform the CTO and maybe after, not during the same procedure, but after some week or some months, to perform the evaluation on the LAD to see if something is changed.
Okay, thank you. And we'll just probably take one more question, which is at the beginning about tips and tricks. So, as you know, we're all young interventional colleagues connected together. My question is, when you are, let's say, do you normally decide upfront that in this patient, I want to perform post-PCI physiology, or it's a decision that, you think, okay, I'm not sure about my results, let me do post-PCI physiology? Reason I'm asking is, if you decide upfront that you're going to perform post-PCI, do you then perform the PCI on your physiology wire, or do you use a normal, let's say it's a standard lesion, or do you perform the PCI on your normal workhorse wire? And then the follow-up question to that is, do you have any tips and tricks in terms of, we see a lot of drift sometimes with these physiology wires, and often you have to, if you've performed the PCI on the physiology wire, pull that physiology wire back and then go back in again. So how do you practically in your cath lab manage the choice of wires and performing the measurements?
Okay, yes, it's a good question. Yes, in our practice, if is not a very difficult lesion, we try to perform the functional evaluation on the FFR or IFR guide wire, and for the drift, I think that is important to test it after the PCI. So if you decide that your procedure is finished and you need to check the final result with the FFR or something like that, I think that is important to check if you have a drift, because as we have seen, this may change our result, and it may change our action to react to this result. So I think it's important, every time is important to check the drift if you use the same wire to perform the PCI.
Okay, thank you. So we've just come up to time, so leaves me just to say thank you everybody for participating, your questions and discussion. Andrea, wonderful presentation, really nice job and nice summary. So thanks for joining and presenting. And Matteo, it's always a pleasure to have you joining us and hearing your insights about physiology. So thank you very much. It was a great session on physiology. I hope you all enjoyed it. And once again, from all of us here at Journal Club, we're very much aware of situations and what's happening in the world with the conflicts in Ukraine, and everybody's very much in our thoughts and wishes. Please, as we mentioned at the start of the session, there's this wonderful initiative which has been started by Jize Young. So here is the, you can see on your screens, you can either connect via the QR code, or in the chat, we'll just post the link and you can donate and contribute over here. Leave this on for the next few minutes. Everybody can access this. So thank you, everybody. Have a good weekend, and we'll see you next week.